Thank you very much, and welcome everyone. Good morning, and since it's a live stream, good afternoon, good evening. I hope we have plenty of people connected because we will have a very interesting session here. For those connected on live stream, you don't know that the UK pavilion here at COP is one of the most popular. And it's one of the most popular because they are the only ones who have decent coffee. Can you believe it? UK decent coffee. I leave it there. I leave it there. Probably it's from Brazil, so let's give some credit to Brazil. It will be my pleasure to moderate this session. With your permission, it's a great honor. My name is Maria Neira, and I'm the Director of Environment, Climate Change and Health at the World Health Organization. You heard about it, huh? WHO, yeah? Okay, thank you. And today we have a fascinating session because, I say fascinating because it's talking about real business, real things that we are all very much concerned about. It will be an opportunity to hear from both UK and Brazil about their health systems resilience and climate action, and the disease threats that we are confronting, how they are preparing their surveillance systems. So it gives me a great pleasure to start the panel by giving the floor to Dr. Ethel Maciel. She's the Secretary of Environmental Health Surveillance, Minister of Health, Brazil. And I think Brazil is very much on the headlines today. So Ethel, over to you, please. Yes, please. I will invite all the panelists. Thank you for doing it. You know, fantastic. I told them in advance that they are not doing it spontaneously. I told them to do that. No, this is calling on climate change business is called adaptation. So fantastic. Thank you for that. So Ethel, now, yes, you have the floor.
Thank you, Maria. Thank you very much for the UK to invite us here. It's a great pleasure to be here with you. And the Brazilian health system is very much inspired in NHS, and we have a long time collaboration with UK. And right now in Brazil, what we are trying to do to build a resilient system. In last year, when we have this new government, when the President Lula was elected and we start this new government, we asked WHO to evaluate our system in Brazil for the international sanitary regulation. We have the commission from the WHO that came to Brazil. There is a 1-year process, and they came to Brazil this year to evaluate all our system. And about a month ago, we received the report for this evaluation. So this was very important to us because sometimes it's very good to have an outside view, outside evaluation for what we are doing. We are the first country in the America to do this, to open the country to this evaluation. It's not so easy to have a lot of people looking what we are doing right and what we are doing wrong and what the challenge, but was very interesting experience because we have the opportunity to have this report and this report to show the challenge that we need to address in this preparation for the probably new pandemics and epidemics that we have. And one very important point that we already know, but it's important to see how the Commission was addressed this, is the lackness of the empty space that we have in the Amazonia region, especially, and what we already are trying to build some more resilient health system on that region specifically, because in this region sometimes, because it's a protected land, we cannot like building or constructing some health units or hospital. We have to need to think in a whole completely different way to build this facility in this area. So we don't have like a lot of experience in this, and we are looking for other countries, other experience, and for this very difficult area to access, like the indigenous landing. Sometimes we need to, there is some landing for the indigenous that we only reach them by river, others only by airplane. So they are very, very, I don't say complicated, but it's very challenging to make the health system in this place. And in the other hand, it's difficult to not have nothing, because sometimes these people need to travel 15 days, 20 days to have to reach some facility. So what we are doing now is to have like a mobile lab to reach this region, floating health units, and this is completely different for us in Brazil. And this is what we are doing to building this more resilient health system in this region that was appointed by this commission that are the most challenge point for our surveillance system. And saying that, the President Lula was committed this and funding this initiative to build this health system in this place. This became a priority for the government. So, Maria, I think I'll leave this, finish this part, saying that we want to collaborate even more with UK, and whatever we can have more deep collaboration to strengthen our surveillance. So thank you very much for the invitation, and I think we can work together in the COP30 for the next challenge for the world. Thank you very much.
Thank you very much, Ethel. I don't know if people want to applaud, or we keep it informal, but still applaud, whatever model suits you. Let's stay in Brazil. I have a good friend here, Dr. Agnes Soares. I will pass you mine, don't worry. And she is, by chance, the director of surveillance system. So I'm sure she has something to say about that surveillance system in Brazil. Agnes?
First, thank you for having us here. I think this conversation is much needed, and I think the more we have, the more we can learn from each other. I'm not the person in charge of surveillance systems. Our secretary is a whole secretary is on surveillance systems, but the environmental part of it, the occupational part of it, is related to what I do. So, and I'm not going to repeat what Ethel said, but in this evaluation we had, the environmental part got one of the best grades. So, because we thought if you had to start somewhere, we needed to start increasing our capabilities of not only increasing the knowledge of the whole health system about environment risks, but also being able to capture where the major risks are and when they are happening. So part of what we do is also in these systems, during the weekly meetings, the risks that are related to the environment, and particularly the risks related to climate change, they are also taken into account. So this gives us an opportunity to immediately speak to the whole health system. So we are not a separated box like it used to be, where only a few people would address the problems and not everyone. So because these meetings always have also other institutions and other related ministries, representatives, normally the technical people. We also know when, if there is a risk, for instance, of heavy rains or a risk of heat waves, immediately we are addressing it in an institutionally prepared way. And this seems very simple, but it's not. Even when we talk about heat waves, at first, people would understand like, oh, it's a good day to go to the beach. So the messages were much more, oh, wear hats and protect from the sun, and not exactly heat waves kills you if you don't take care. So this has been changing, and I think it's much of this idea that the whole health surveillance systems has to take into consideration these risks. And the other thing I would like to mention is Brazil is a very complex country. It's huge, but it's also 6 different biomes with different risks and with different challenges. And when it's related to I think surveillance, the main, I would say the most important thing is to keep communication easy, even when you are in a crisis. And it's not easy. It's really I would say, the major challenge we have nowadays is exactly that. Because I think we have one of the the largest system that is all connected, and it's all, most of it digital. But when you you have a problem with electricity, and the first thing that fails is electricity and internet, and then you are blank. So I think there are many ways to cope with this, and that's the reason not all the solutions are within the health system, but that we have this opportunity to speak about this because we have this institutionalized ways of meeting regularly to talk about this situation. So this happens. For instance, when we had all the viruses risks, and because sometimes it comes as avian flu, and then we have different actors. But then we speak where this will happen, and then the environmental area will say what we think this could happen. So I think it's a big challenge, and we look for examples from outside. And I know there is a reason we are here together. We have been searching collaboration, and we have many ways of collaborating because both countries have health systems that are connected, and ours is unified. And of course, the size is not exactly the same. The challenges are not exactly the same. But we look at UK to see how these things were worked out, and we look forward to hearing more about that. Thank you.
Thank you very much. Just to remind that Dr. Agnes Suarez is the Director of Environmental Health Surveillance, which is a very big task, and reminding us the importance of this communication on emergency preparedness. And I'm afraid, being from Spain and watching what's happened in Valencia a few weeks ago, you are absolutely right on the importance of knowing how to communicate and making sure that the population will react to that. So it gives me now pleasure to introduce Kansa Ahmed, Global Policy Health Advisor and Epidemiologist, UK Health Security Agency. I'm sure you have something interesting to share with us as well.
Yeah, thank you very much. And from our perspective in the UK, we welcome the collaboration with our Brazilian counterparts. I think it's a good opportunity for two-way learning from each other, because there are some things in which our Brazilian counterparts are ahead of the game, thinking particularly around extreme heat, for example. The UK is starting that journey and starting to learn some lessons, but I think our Brazilian counterparts can teach us a lot around that. In terms of the UK, we know infectious diseases do not stay within their borders. We know they cross borders, and that's why this sort of cross-collaboration is incredibly important as we go forward. So to take it to the technical level, the kinds of surveillance systems that the UK already has are things around like real-time syndromic surveillance. So that effectively is really interesting and useful, and something that actually other countries could pick up on. Now, real-time syndromic surveillance, for those of you who haven't come across it before, is essentially if anybody calls our emergency service or goes to their primary care service and says, I have a cough, or I'm not feeling well, or I feel very tired, we pick up on that. It's not a diagnosis, but it tells you something is happening. It's our early warning that something is happening and that we actually might need to pivot our services to cope with whatever is going to come next. And I think that's really important because in a lot of countries don't have diagnostic capabilities, that finance isn't available. Or, as was said, people live so far away, it takes too long to get a diagnosis. But knowing about the syndromes, the symptoms that people are experiencing is really important. The other thing we've been doing and taking the environmental side is our entomologists at the UK Health Security Agency have been doing a lot of vector surveillance. So looking at, for example, ticks and mosquitoes. And that gives us an idea of what's happening. So it's actually taking the animal health before we begin to look at the human health, because actually the early warning is there within the mosquitoes, within the ticks and other vectors. It's not there. By the time it gets to human health, we're too late down that journey. So we're already looking upstream to see what's happening. But also, what we recognise is that infectious diseases don't operate by themselves. It's normally as part of a much bigger cascade of hazards. So what we have is what we call an all-hazards dashboard, which looks at everything else that is happening across the UK, including the weather, so information from our Met Office. It could be other incidents. It could be communication issues, for example, are all on this dashboard. So we know at any one time what is happening on a daily basis and able to see the context within which this infectious disease outbreak is occurring. And I think that's really important, that we need to contextualize these outbreaks. At the international level, we have been working with counterparts in Rwanda and Ghana through the Office for National Statistics, through a Wellcome Trust-funded project, and that is to develop indicators to measure the impact of climate change on health. Now, everybody's been doing it differently, and I'm sure if we would speak to our Brazilian counterparts, they have their own measurement system, and we have our own, but we can't actually understand the true burden of climate change on health. So this indicator set that we are developing will actually be, hopefully, if we're successful, adopted by the UN in 2026. It'll become the global set by which everybody can measure, using the same methodology, the impact of climate change on health. And that's going to be a big step forward when thinking about future COPs. So Brazil onwards, we'll be able to have a better idea of what's really happening and how we all measure things. In the UK, UK Health Security Agency published a report known as the Health Effects of Climate Change, or the HEC report. And within that, we noted that it's important to have a multifaceted approach when it comes to surveillance. So we need to be looking at sentinel surveillance, epidemic intelligence, routine surveillance, the daily stuff that comes in through primary care, but also taking genomic data as well, because that tells us how infectious diseases are mutating and what might be coming up next. And so taking that sort of broader approach in the future is going to be important if we're going to get full understanding of the impacts. The other thing that we're thinking of exploring, and is something that actually a lot of countries could potentially do, is looking at private sector data. Our private sector colleagues hold a vast amount of data that can give us an indication. For example, in your supermarkets, you will sell paracetamol, you will sell cough medicines. If we understand when the number of sort of cough medicine purchases is rising, that tells us that something is happening in the community before it hits the health service. So it's that early warning system that's really important in understanding how infectious diseases are progressing. But also, just taking on the point from our Brazilian colleagues, taking a One Health approach is important. If we're looking only at human health, we're too late. We need to be looking at the environment. We need to be looking at animal health and actually understand what is happening and build that into our systems and have unified systems rather than trying to operate in silos. And I think that's something that actually we can work very closely together at understanding how we take a One Health approach and a common framework around that. Ultimately, if we're going to have successful infectious disease surveillance, it's got to be a multi-sectoral approach. It can't be just left to human health to look at infectious disease. Everybody, including our colleagues working in the Met offices, looking at the weather, looking at what purchases are happening in terms of medications, procurement, all of those things, they all form part of that picture that tells us what's happening. And ultimately, the planet tends to give us the early sign that something is about to happen. So we need to start listening to the planet a little bit more if we're going to actually protect humans better. So again, we really look forward to working with you. And I think there's a lot of opportunity in terms of technical expertise and advice that we can share with each other as we go forward. Thank you.
Very critical points. Thank you so much, Kenza. Dr. Thomas Waite, Deputy Chief Medical Officer, Department for Health and Social Care. Over to you, please.
Thanks, Maria, and many thanks to Brazilian colleagues and to Kenza for the input so far. I'm going to add just sort of 3 key points to what Kenza has already said. The first is on the actual health impacts of climate change in the UK. Not many of you will need reminding about that. If you're here at COP, you probably already know what they are. But the second is to talk through how we use the surveillance outputs that Kenza has detailed to pull those into policy. And I'll talk through a little bit about how we do that in the UK. But the third, and I think the key thing, is first of all, these are not impacts that are felt equally even within one country as well as within the world. And to be really clear about how we then turn that into the sort of language that works beyond health, as we're sometimes very good at talking to ourselves in language that we understand, and we do need to think a little bit more about how we engage, particularly with finance and with treasuries around the world, which is one of the themes of this year's COP. So you all know what the health impacts of climate change are. They are related to changes in temperatures. They're related to changes in the water cycle. That drives infectious disease as well as extremes of both heat and cold, and a range of disaster-related impacts. In the UK, that is currently principally about the change in the number of people exposed to extreme heat, although we can see from the sort of maps that European Centre Disease Control puts together that vector-borne disease is coming our way, so there's a range of things we need to prepare for. But even within extreme heat, we know we're not at the forefront of that yet, but it's coming. So the IPCC projections from a couple of years ago project that there are parts of the world where already the combination of heat and humidity, and I think this includes Brazil, is approaching the point where 365 days of the year people are exposed to potentially serious, potentially fatal combinations of heat and humidity. And that only increases north and south under each of the warming scenarios. We're not at that yet in the UK, and we probably won't actually under any of those, even the more extreme scenarios. But already we see over 2,000 heat-related deaths per year. And in 2022, when we saw record-breaking temperatures, particularly in the south of England, but actually all over the country, we saw almost 2,500 deaths related to extreme heat in a fortnight. So this is a real and increasing problem in the UK, and we get that sort of information from the surveillance systems that Kenza laid out. They also tell us that this doesn't affect everybody in the same way. So almost all of that mortality was in people who were aged over 70 or the very young. And a recurring theme, I think, people will have picked up from yesterday, from the Human Development Day, is that the greatest impact, but also the greatest change we can make, is the impact on children. As over their life course, they will be exposed to the greatest range of climate impacts, as well as at very young age, they are less able to adapt their physiological response. So it's an unequal impact, but it's also an impact that's affecting the poorest in society. The people who live in inner city housing, this is least well adapted for climate change. Not unsurprisingly, we build our homes to be good for the cold in the UK. I'm afraid we're not famously warm, but less good for heat. And there's a huge amount of the work that can be done there. And that actually overlaps with a lot of the inequalities that were revealed, I think, to wider society during COVID. It is the same population groups affected by heat that were affected during COVID in various ways, including the homeless, including people who were in various care settings. And we know all of that in quite granular detail from being able to have good integrated environmental and health surveillance systems. But then there's a look at, well, what do we as policymakers, what can we do with that information? And for those who haven't seen it, there is an excellent report by the London School of Economics and the Grantham Institute looking particularly at heat, but at climate change overall and how we should move to more integrated approaches. In the UK, we've had a Climate Change Act since 2008, and that's got a range of provisions in it. It's been very helpful actually to many of us working in health in lots of ways, but it requires every 5 years a cycle of a complete societal assessment of the impact of climate change, which comes to a climate change risk assessment that's done independently by the Climate Change Committee. And then the government has to respond through something called a National Adaptation Programme. We're on our third cycle of that. And that's highlighted to us, again, drawing on the evidence that comes from the work of the UK Health Security Agency and others, that the impact of extreme heat in hospitals, as well as in care settings, is one of our key risks now. That's gone up and up. And there's a range of actions that we need to take to adapt to that, but also there's a lot we can do to mitigate it. As the health estate in the UK is, we have a very large National Health Service, as Chris will talk about in a little while, but there's a lot that we can do both to adapt and to mitigate climate change. Within it, though, we found some quite surprising things. So there's a researcher in the UK, Ross Thompson, who looked at the impact on mental health of the heat waves over the last few years and found a 10% increase in admissions or presentations to accident and emergency, admissions to hospital during periods of extreme heat. So there's more work we need to do on another of the groups that is more exposed to the, sort of the unequal impacts of a range of different things. So that integrated policy and the National Adaptation Programme in the UK looks like the health effects of climate change work that Kanza mentioned. It looks like the establishment of the Centre for Climate Change and Health Security, which is part of our UK Health Security Agency, and the work that is done there to try and move on from having excellent evidence and pull that into practice. But the third point then, I suppose, is we've got to be based on evidence. And we've got to turn that evidence into economic benefits. We spoke yesterday at an event that both Maria and I were at about trying to explain why some of the gains we want to make in health are bankable, what that means in terms of a mission-led government which has growth as its core. And essentially, if we are keeping people healthy, that is critical for growth. If you have people who are off work because they are directly unwell, off work because they are caring for loved ones who are unwell, unable to work, or indeed there is a whole range of different ways in which keeping people healthy or protecting them from the health effects of climate change is going to be vital to all of society, and we need to get better at doing that. So translating our language, our acronyms into ways that speak to economic benefits is important. And we know from some of the work by Emma Howard-Boyd, who was asked to look at a review of London's climate change resilience, that the return on investment for example, heatwave planning, for creating heat resilience infrastructure is enormous. You get back £2 to £10 for every pound you spend on stuff that is health related, and that's of a benefit to us all, right the way across the UK and globally. But just to sort of cap off, this is a global picture. As I said, we know that we're not seeing the most severe impacts of heat in the UK yet. We learn from the Brazilian experience, and we really look forward to COP30. Both Brazil and the UK, alongside UAE, Egypt and Azerbaijan, yesterday signed the Continuity Coalition for Health and Climate Change, which I think is going to be a really important driving factor for continuing this discussion into next year, building on the commitments that we made at COP26 and taking this forward, because, as you said, Maria, this is the priority. Climate change is a health problem, and we need to work with policymakers right the way across governments of all colours and in all countries to make absolutely clear that the reason we all do this is to protect the health of people so they can live long and healthy lives. Thank you.
Absolutely critical points. Not only we need to do surveillance, we need to do policy recommendations. We need to make sure that those policy recommendations are multi-sectorial, and we need to make sure that we explain the return on investment. That will be our winning part now, and this is reassuring the fact that health is the argument for climate action. I think if we are able to put on a very good narrative the way you just did it right now, maybe we will win and we will have something very tangible at COP30. I'm pretty sure that it will be the case. Chris Gormley, you are the Chief Sustainability Officer in the UK, of course. UK, England. Sorry. And I'm sure you have a lot to say as well about sustainability of the health system. Thank you.
Thanks, Maria. Thanks to my previous panelists. So, look, in some ways, I'm a bit of an interloper on this panel. My core day job is to lower carbon. I run a team in NHS England to try and decarbonise our NHS. But, just on the cost point, I mean, the health effects on climate change report, which was mentioned earlier, I think it estimated that the cost to the NHS in the 2020s on a medium-term scenario would be sort of £6.8 billion per year, and looking forward that would rise to sort of £15 billion by 2050. So I think we know that actually the costs of adaptation resilience, we need to think a little bit about mitigation. That's one of our core aims in NHS England. So that's why we have in 2020 we launched a strategy very proudly. The NHS was one of the first health systems in the world to launch a strategy to decarbonise its health system. We set some really, really ambitious targets. So we want to decarbonise everything, all of the emissions that we can influence by 2040, with some really strong interim targets to reduce by 80% by between 2028 and 2032. And for those emissions that we can influence, so those are our supply chain, a big part of our emissions is our supply chain, we want to be able to hit net zero by 2045. And look, that's no mean feat. The emissions of the NHS, and I think healthcare globally, is around 4 to 5% of global emissions. And if we were to think about the NHS as a country, I think back in 2020 we estimated it to be roughly around the size of Croatia. So it's a big task, and there's a lot to do. We have a relatively small team, but we work across the entire NHS. We have 1.4 million members of staff who are going to help us decarbonise our NHS. And some of what they're aiming to do plays very much into the resilience question as well. So we've talked a lot about how we heat and cool our buildings. We know that 15% of our emissions are related to our estate. We've already secured over £1 billion through the UK government to be able to implement things like heat pumps, things that really can help control ambient temperature in our hospitals. We know that our hospital estate is actually several of our buildings are hundreds of years old. It's very, very difficult to decarbonise our buildings, but we're making real progress there. We have a travel and transport strategy. Again, it shows that the benefit of reducing the emissions. We have the second largest fleet in the UK behind Royal Mail, and we know that those emissions are impacting our patients. 36,000 lives a year lost through air pollution. And we're part of the cause of that. So we've set out a really clear strategy to decarbonise our fleet, and by 2035 our fleet will be zero emission vehicles, apart from those specialist ambulances, which will take a little bit longer. But these are really key interactions, not just for mitigation, but also for improving the resilience of our health system. And I think, again, going back to those 1.4 million staff, we have a real challenge and a real opportunity as well to teach our staff about how we're going to decarbonise and how we're going to become more resilient. So we are, as part of our programme, we have legislation which says that we must meet the Climate Change Act legislation, which Tom mentioned earlier. But as part of that, we also have we put a responsibility on every single hospital and every single commissioning body to produce a green plan which sets out how they're going to decarbonise. And as part of that, they also have to produce adaptation plans as well and assess the risks of their hospitals. So we have a lot going on the NHS. I hope we have a touch where actually it's a really important day today, Maria, for you and the WHO. And I hope that we can spread some of that learning that we've managed to bring forward through the NHS through Attach.
Thank you. Thank you. And you know very well that we are looking very much at NHS England as a model for Attach. So you better behave and you better produce results because you are our kind of a star. We need to follow that. So thank you very much. And yes, it's a big day today for Attach, and we count very much on all of this experience. But we have time now for another round with our panelists. And I would like to ask you, all of you, kind of, not a provocative question, but essentially, how prepared you think we are to respond to the threats of climate-sensitive infectious diseases in all sense? I mean, our surveillance systems, but as well the policy recommendation, the communication with our citizens, the integration with the climate change, and maybe you can share as well some best practices. And I'm sure you have a lot of experiences and obstacles, but and we all need to learn from each other and how difficult I'm sure it is every day. So do you want to start, Ethel? Thank you.
Thank you. I'm just looking that we are side by side, Brazil and UK. And I would like to finish my intervention here to take what Agnes say about communication and this beautiful picture from the indigenous population in Brazil, and tell us a little history how health can be a case for the climate change. I have, in my first week of the job, and this is one history for the book, January 7 to 2023, I have a report in my hand saying that 3 indigenous was dead because they didn't reach the hospital in time, and the death was for undernutrition. And I was, why in the 21st century someone is dying by undernutrition in this land? And probably do you remember that the Brazilian and UK that was killing the Amazon region for the, and we know that there is something happened there, but we didn't know exactly was because it's the other government, and we didn't know exactly. And this caught my attention, and I sent a epidemiology team, field team there, and they send like a horrible picture. Never forgot this, like horrible. And people are this terrible image, and we are start to receive data because there is no data. We do not know what's happened there, and this with this we made the case. We wrote a technical note. We sent for the minister, for the president, and the president decreed a health emergency in this area. And because of this decree, we were able to enter in this land with the army, because there is a lot of illegal miners. They are dying because all the water was contaminated with mercury. So they are dying because the water was, they couldn't get to because they hunt. They cannot hunt because the army, the miner is armed. So the legal miner is armed. So there's a terrible situation. And the Yanomami, these people, they don't speak Portuguese. We have to reach them with a special people that speak Yanomami language. They didn't speak this, and they have a very important culture habit. When some people die, they burn everything that belonged to the people. So we don't know how many people was dying there because there is no data. And we have in this area, it's a huge area in the Amazonia region. We have like 8 health units. And out of these 8 health units, 7 was closed when you arrived there. There is only 1 physician and 2 nurses for huge area. And how this communication is so difficult. So we went there, we made a lot of things. And we have data. And suddenly, we have 30 people was dying, or there is death, and we have a lot of cases of malaria. We treat them, and we got attacked because our government was having a lot of people that was dying, was with malaria. So it's very hard to communicate what we are doing. I'm a full professor of epidemiology, so I have to stand up to say, we have 1 physician, now we have 60. To have a death certification, you have to have a physician to make this happen. So when you don't have physician, you don't have death certificate. It's that simple, but it's still very complicated to communicate to society what we are doing. So there is a lot of challenge, but this is a very small example that health change everything that we are doing in this land right now in Brazil. We have almost 2 years there. A lot of things was changed, but in the first time, it thinks that was for a very bad way, not a good way. And we have to explain when every time that you look, you find something. You have more diagnosis, you have more everything. And work with transparency, it's not always translate to the society that we are doing for better that was happening there. What we knew now, it's from 3 years ago from now, 4,000 indigenous missing in this area. But we don't know what happened with them. Because we have time to time the census in this area and missing 4,000 indigenous in this land. So probably a lot of things going on that you never will know, but now we are there. We are doing our job. But it's very hard to communicate this. That is a good thing. It's not a bad thing. Communication, I think it's a challenge in this moment. In this moment in the whole world, we are seeing the US election and looking very worried what was going on in the world, and we think that we need to have a better communication, as Agnes saying about the high waves, how you communicate this, because for climate change, it's still so abstract for the people, for the society. So we need to communicate better, to have different words to tell this. And I think we have a lot of things to share, but we don't have time. But I would like to thank you the UK for the opportunity to be here, and look forward to work more close together. Thank you.
Thank you. Thank you very much, Ethel, and thanks for sharing this fascinating and impactful story. I think you mentioned about a book, so I encourage you to put it on a book. Yes, definitely. I think it's a very good idea. Agnes?
Okay. I think the most difficult situation is to get information right. And when we talk about environment, it's even harder. And I could say, if we look at everything that we have to be counting for, water is the only thing that is the responsibility of the health system. So we have surveillance for the water quality. It's the water that gets to people. But that's a really strange situation that we don't have any power. We recognize the problem, and then we have to say somebody else has to take action. And this seems easy when you talk. It's like sending a report and said, please do something about it, but it never happens. So exactly for the same reasons, of course, problems don't come alone. So when you have a big crisis, you have not one big crisis. You have on top of one, you have 2, 3, 4. That's the problem we have to deal with. But last year, we already knew we would have huge problems with water scarcity in parts of the countries because we started talking. We were looking at the water quality. It was changing in some places where we do have control. That must be said. But we knew reports from places, particularly in the Amazon, that even after the drought period, that it cycles from a drought period, and then you have a flooding period in the Amazon. But the people living there, they said the rivers did not get to their levels. So, and we knew from from the projections that we would have a worse scenario this year. But nobody wanted to talk about it. And when people started paying attention to what we were saying, when the fire started to reach everyone, not only the people living in the Amazon or in the Cerrado and other places that were burning, but when the smoke got to Brasilia or to São Paulo or to places that what is happening, and then suddenly it became a huge crisis. However, we had been working with this and trying to put this into the center of attention. And everyone was worried about the smoke, and we were worried about water because we said the basics is the water, so people cannot get there. And it's difficult to understand that in the Amazon, when the rivers dry off, there is no way to get to the people living there. Even large communities, because the whole system, supply chains without water in the Amazon, how do you get there? And how do you take, I'm saying we have to decarbonize, but how do you make generators work when you don't have, there is no other system. So we need to do a lot to make off-grid solutions that are not a problem that the health sector alone can solve, but this is what happened. So in the middle of this situation, what happened, we organized the situation room, the climate emergency situation room. And this has been a very important way of organizing the information and speeding up what we had to do anyway. So mapping and geolocating all the communities. It's not only indigenous, there are riverside communities and traditional communities, quilombolas, and we didn't know where they were. If we had to say, so we had to call experts about which rivers are now at higher risk, where are we going to, what is the next emergency? And all people asked when we had the emergency, how many people are dying? Can you report every day? I said, no, we are working because we don't want anyone to die. So it's exactly the situation we have to do. It's environmental health surveillance. It means we don't want to get to the epidemiological counting of death and disease. And so I think we deal with very complex problems. And we need different solutions. The way we're working it may work for the majority of places. And I would say it's difficult to say because Brazil is like 90% of the population lives in cities. They live in cities. So, of course, if you deal with that, you are dealing with 90% of the population. But what about the 10% that are there and that are we leaving them by themselves to, save yourself anyway? So we need all the solutions. But also when we started putting all these things on counting and looking at how we could make a better use of data, then we had a very small state that was the only one that could provide us timely data. It means they were all connected. It's also a Brazilian priority to get these connections. So we used that to project to the others what was happening. So the situation room is still on, but now we don't meet every day, and it was a crazy period. But it was a very intensive learning process for not only for the people there, but for everyone involved. And this made also people from that were projecting rain and the people looking at the rivers, they said they understood why they had to provide us with the detailed information. We are putting these all in the map. And now we know, and then we projected that, the next one is Pará. So we sent people there, and we identified before the rivers went down to take the provisions and the water that they needed before we got to the worst case scenario. And then they say, okay, but if the big crisis didn't kill so many people, then it was not such a big crisis. No, it was, and we didn't want them to die. So I think this is, of course, it was kind of a learning in the process for everyone. So, but what we saw is even the people working with climatologists, they like to do all the talk, but they never think on how this can be useful. And so they had, when we asked specific questions, they started to get excited about it, and so they would bring us reports that were better and better. And they started discussing with us, and this changes the projections. Up to now, we have a projection for 3 days, for 2 weeks, and we were learning their languages, but they were learning ours as well. And so I think we need solutions that are not exactly the ones we had before. We cannot work separately, and I think this is the major learning process we have. That's it.
Thank you so very much, Agnes. I think you are touching the principles of primary prevention, and how orphan is normally primary prevention, but we need to go for that. The health system, the health sector has the good diagnosis. Our prescriptions need to be implemented, and for that we need other sectors, how to convince them of all of that. So let's go, keep pushing, because it's a common sense, good sense recommendations what we are making. Kenza, we are running out of time, so I know that you have fantastic things to say, but I'm asking you for 2 minutes.
I will keep it brief, thank you. So in English, we have this saying that when you're walking down the street, you don't trip over the mountain, you trip over the pebbles. And the way sort of the climate change crisis is going is there's lots of pebbles, and we're trying to stay on our feet and keep ahead of the game. So just very briefly, I wanted to raise sort of a couple of things. One was around having a sort of key approach when it comes to thinking about the public health. So, thinking about how you communicate with the public, but also how do we communicate with journalists around this, right? We publish data, we publish reports, but for the ordinary person on the street, what does that mean? What do they do? How do they take control? And how do they protect themselves and their families and their communities? Those are the questions we need to be answering as part of our communication. And that can be through the media, social media, and other ways as well. So people can, so it doesn't become a conceptual thing, it becomes a very real thing. The other thing I briefly want to touch on is data. And making sure actually that we're sharing that information across the board, because ultimately, if you're not measuring things, you can't manage them. And that's key. So you can't manage what you can't measure. So it's really important that actually we have a better understanding of what the data is showing us down to disaggregated levels, so we can see what's happening with our vulnerable communities. We talk particularly about the Amazonian communities, who is being affected and how can we target the policy so that they benefit and they're protected. So thank you very much.
Thank you very much, Kenza. Thomas?
Thanks. You asked for brevity, so I'll just cover three very brief points. You asked also about infectious diseases, I think, particularly in preparedness. So there are lots of different types of impacts for that, but principally I think we're talking here about food and waterborne diseases, and we're talking about vector-borne diseases, there's a range of others. On food and waterborne, even during major extreme flooding events in the UK, we actually don't see an enormous impact. That is because, Maria heard me say yesterday, you don't need a doctor when you're trying to deal with preparedness for preventing infectious diseases related to sort of food and waterborne around climate change. That's an engineering problem. We solved this thousands of years ago. The Romans solved this. We know how to separate clean water from wastewater. Yes, there's a need for sort of maintenance and making sure that is a global point, but we see relatively small impacts of that from flooding in the UK. We do, however, see a huge impact on mental health. And that's something I really don't think we should forget amongst the focus on infectious diseases. Up to a third of people had long-term mental health impacts after the 2013-14 floods that actually affected all corners of the UK. So let's keep that in mind. On vector-borne disease, actually I think it's a very different setting, and this is somewhere where I really think we could learn from your experience in Brazil, not just with Oropouche at the moment, but a range of vector-borne diseases. We have malaria in the UK until well into the 20th century. It's only just about 100 years ago that we ceased to be an endemic malaria region, but I think we have a lot of learning to do on both what our preparedness is as a system, but also how we work with the public and explain the actions that would need to be taken. Lots of people, I think, are now used to how we tackle respiratory pandemics and major infections in the UK. Mosquitoes don't care about your lockdown. So the public mindset for how you would need to respond to an outbreak of vector-borne disease is something I think we could do a lot of work on. And I'm very keen that both as governments and those who are sort of in sort of governmental positions, we learn from each other, but also work on research, on science, on development between the institutions of the UK and Brazil to do our best practice on that. But the single biggest area, I think, where we see health impacts at the moment is related to air pollution. I know this is pushing infectious disease now into non-communicable disease, but globally 7 million cases per year people die related to air pollution deaths. Those are principally down to heart attacks and strokes. We can find those, but the actions that can be taken right the way across the net zero agenda have a knock-on win for health if we're reducing emissions, particularly in built-up areas, but that's a major win-win for health and for the rest of both growth and net zero. So a few places where we know we've got good surveillance, but I think for us it comes down to primarily non-communicable disease and preparedness for vector-borne disease. As we can see the vectors coming, disease will follow.
Very happy you touched on air pollution as well. This is one of the best sellers we can have as the health community to prove that there are health benefits if you tackle the causes of climate change, and we're using our language to prove that you can reduce the cost, and of course you can reduce the deaths and all of that associated. Let me go to my final speaker, leave us on something positive on sustainability. No pressure.
Oh my
Chris.
goodness. Okay, well look.
Give us some hope.
Yeah, look, every year we understand our carbon footprint pretty well in England, in the NHS in England, and we have actually shown that since we set our target in 2020, every year we have seen a reduction. We are able to make a difference. We are able to make a change. It's actually the healthcare profession, perhaps more than any other sector, who is willing and understands the impacts that we've just been talking about and the opportunity and the challenge for the healthcare system in the future if we don't change. So I actually feel quite encouraged that at least our staff in the NHS, and actually I see it globally in so many clinical and nursing colleagues who are here at this COP are really, really passionate about this and really want to make a difference. So I am actually quite hopeful. I can see the change we're making. I'm pretty sure we know a number of other countries are making those changes as well. So I feel positive.
And I think this sustainability effort is very motivating for our health professionals. They are very motivated and enthusiastic, so I feel the positive approach as well. I don't know about you, but personally I think it was a very rich exchange of experiences. Who will think that UK and Brazil will have so many things in common, but they do, and maybe it was a signal, the fact that the two pavilions are back to back, and that's maybe the reason why the coffee is so good. And definitely thanks for this very rich exchange, best practices, feeling and making sure that we learn from each other on this critical moment, and passing all of this passion and knowledge to the negotiators here at COP for them to understand that they are negotiating with our health as well. So we need to have a word on what they are doing. Thank you so much. I need to run to the energy, so I leave you here. Thank you so much. Thank you.